Okay, so we are live now on Facebook. All right, so good evening, everyone. I don't know, the speakers, we can have our video on now. Good evening, everyone. Yeah. Welcome, Dr. Esther.
Thank you very much, Dr. Samuel.
Yeah, welcome. Okay, so I'm going to, yes. Okay, so we have you pinned. Welcome, Dr. Ajay. Okay, yes. And
glad to be
you're
here.
welcome. Thank you so much. Okay, so yes, we're good to go. I want to welcome everyone to this session. I'm sure it's also been broadcast on Facebook Live. It's the World Cancer Day celebration 2023. And this is, of course, put together by Standard Alliance Foundation, the platform basically to educate all our listeners, all the public, basically on the reality of cancer. So World Cancer Day basically is celebrated every year, 4th of February every year, where they basically create awareness on cancer. It's a platform where we get to educate people, and of course, sensitize both the people, the general populace, the policymakers on how we can get to, of course, stop this issue of cancer all over the world. Of course, in a particular way to celebrate this year, we have been able to bring together a panel of experts. We have oncologists, we have public health physicians who will be telling us all we need to know about cancer. Okay, you will agree with me that cancer is one of the leading causes of death globally, and because it presents late, a lot of people most of the time usually do not get to survive. So this, of course, is an initiative brought about by Standard Alliance Foundation to celebrate the World Cancer Day 2023. Without wasting much of our time, I would want to welcome our panelists. We have 3 great panelists on the call right now. In no particular orders, or maybe I should go with ladies first. I have Dr. Esther SAF-NG. I hope I didn't murder your name, Dr. Esther. Did I get the pronunciation correct?
No, you murdered it for sure.
Okay, maybe you should help us with the correct pronunciation then.
Okay, it's Esther SAF-NG.
Oh, SAF-NG. Oh, so I really did murder it. So you're welcome. Dr. Esther is a public health specialist, and she currently works as an NCD risk officer with the World Health Organization African region. Once again, thank you for joining us. Also, I have on the call 2 radio oncologists. I don't know if there's a clinical radiation oncologist. These basically are doctors that specializes in the care of cancer patients. I have 2 of them. You need to know it takes a lot for you to have them because they're always busy attending to patients with cancer. Also, in no particular order, I want to start with Dr. Demola Oyekon, consultant radiologist, radio-oncologist with Lagos State University Hospital. You are also welcome, Dr. Demola.
Yeah, thank you very much. Thank you for having me.
All right, and I also have a very important person in VVIP, somebody I've known, a very, respected elder, of course, in the Palance of Area when he was still a resident doctor, but now he's a consultant radio-oncologist, person of Dr. Ajay Ebenezer. You're welcome, sir.
Thank you very much for having me. Good evening, everyone.
All right. So without wasting much of our time, I would have loved to take their profile, but because we took time, so what we would do is that we'll post their profile on the group, and then you can get to read about them. So I hope that is okay, my guest. I hope you will forgive me because of time, and there's so much really that we need to talk about. All right, let's start. the basic question everybody wants to ask, cancer, and I'll be starting with Dr. Demola. All right, what is or what are cancers? When we say cancer, what exactly are we talking about?
Basically, cancers are. So thank you for having me. So cancers are overgrowth of cells. We can call it an abnormal mass of tissue that's the growth exceeds. That means it grows in excess and is uncontrolled. Even when the stimulus that initiated the growth has been removed, it still continues to grow and affect other tissues, and it can even go beyond that site. So that's what cancer is basically.
Okay, so you just overgrowth of cells in the body, right?
Yes.
Okay,
That
so
uncontrolled.
Uncontrolled. So because I was
and
wondering,
grows in excess.
okay, so cells are supposed to grow. How did they stop growing? I don't know if you can. Why did they, and what could be responsible for them growing in excess and uncontrollable? I don't know if you can.
So basically, when there are three types of cells in the body, there are labile cells, there are continuous cells. So the labile cells, they grow by stimulus. I mean, when there's a need, the body tells them to grow, and they are the continuously dividing cells. So the examples of those labile cells are the liver, the kidney, cells in the liver, cells in the kidneys. There is also continuously dividing cells like the skin, the hair. They are always growing, all right? Then the cells that line the throat. Then there are permanent cells like the muscle cells. I mean, once they are grown, they, even when it's stimulated, you may not find them growing again. The muscles of the cells, the muscles of the central nervous system. So what happens is that checks and balances in the body that helps to tell and say, okay, it's time to stop growing. We have grown enough, stop. But these cancer cells, it happens that they don't get those instructions. They evade those instructions. Wow. They don't have a start and stop mechanism. So they are in a world of their own, and they want to have a field day. So they keep growing and they want to take charge of the whole body. So that's the way it is, basically. I think I've been able to explain it in a layman's term.
Thank you so much. So basically, for those that are listening, it's just when those cells just continue to grow and do not follow command, and they begin to give problem to the body. So that's when we say that a cell is cancerous. Okay, thank you very much, Dr. Demola. So I'll go to Dr. Kaji. What part of the body can cancer affect? Are there part of the body that we cannot have that cancer cells, or is it all part of the body that we can have cancer?
Well, thank you. Thank you for the question. The name is Ajay.
Ajay, okay,
yeah.
Forgive me.
No problems. So I think I will tell you the parts of the body that are not affected by cancer. Then we can sort that out. The hair on your head and your fingernails are not affected by cancer. All right. Okay. So it simply just says that, I mean, we know that the hair of the heads are when the hair grows, right? And the fingernails, your fingernails that are chipped off at some point, you know, those are the parts of the body that are not affected by cancer. So it means that every tissue of the body, growing tissue of the body that has got a blood supply to it can be affected by cancer. You know, we have different tissues in the body. We have soft tissues in the body. We have what we could call hard tissues in the body, the bones and the cartilages. These are affected by cancers. Then the muscles, the smooth muscles, the soft muscles, all the other kinds of muscles, they are affected by cancer cells. Thank you. Hello, moderator. Hello, moderator. Can you hear me?
Yes, I can hear you, Dr. Ajay. Please go on. So,
Okay.
yeah, go on, sir.
I had finished making my comment.
Okay, so you said the part of the body that cannot be affected by cancers are the hair, the fingernails, and then you talk about the smooth muscles.
No, I said the hair and the fingernails are the parts of the body that cannot be affected by cancer. However, every other part of the body, the tissues that you have, smooth muscle tissues, soft tissues, hard tissues, can be affected by cancer.
Okay, so practically every part of the body can be affected by cancer, other than the ones that you've mentioned. All right, thank you very much. The next question I have is for Dr. Esther. All right, Dr. Esther, are you there?
Yes, I'm there.
Okay, so now we know what cancers are. We know the part that they can affect. Of course, the next thing I want to find out is that really what are the causes of cancer, or what are those things that could lead to cancer? In other words, are there risk factors for people coming forth with cancer? Or maybe before we ask that, before we go to the risks, please pardon me, let me go back to Dr. Andemola. What are the common cancers? Of course, cancer, they say, is almost the second common cause of death in a lot of people these days. But what are the common types of cancer that we can see, both in male and then in female? Dr. Demola, can you help us with that?
Okay, thank you very much. So there are various types of cancers ranging from the type of tissues that are involved. Well, basically, the common types are the breast cancer, which currently is the commonest cancer globally, both in male and female put together. Lung cancer, prostate cancer, the cervical cancer, colorectal cancer. Those are the common ones. And then in Australia, on that continent, they have more of the skin cancers that take a large chunk of the burden of cancers. All right, so but in our environment, it's more of breast cancer, cervical cancer, prostate cancer, colorectal cancer.
Oh, okay. So in other words, those are the four commonest ones. Breast cancer, of course, in female, cervical cancer, while in men, of course, we have prostate cancer, and then colorectal cancer. All right, thank you very much. So we'll go back straight to Dr. Esther. So what are those things? What are the things that predispose a person from coming down with, or predispose a person to coming down with cancer? What are the risk factors? Can you take us through?
All right, thank you very much, Samuel, for that question. Before I get into that question, it's just important for our listeners to understand the importance of this cancer we are talking about today. And we have to know that cancer, we have an annual incidence of cancer, that is the number of new cases from cancer in Africa is close to 1.1 million every year, new cases. And then we have about 700,000 deaths that are caused by these cancers every year. So this topic which we are discussing today is actually very important. So the next question would be to find out what are the risk factors. Well, we have general risk factors that cut across most of the cancer that we have, while we have others which are specific to certain kind of cancers like breast cancer, cervical cancer, and colorectal cancer. But for those who are general, that cuts across most of cancers, we have modifiable risk factors like tobacco consumption, on unhealthy diets, the harmful use of alcohol, obesity. We also have unprotected sex, which could lead to chronic diseases, which could cause cancers. We have ultraviolet radiation. We have air pollution. We even have also stress. So any of those which are not controlled, which are not put in check, can lead to cancer. And we also have to note that there's a genetic susceptibility to cancer, meaning if your first degree relative has a cancer, there is a tendency that if you don't check on yourself, if you don't do regular screening, if you don't watch over your dietary or your lifestyle, you might end up with the cancer. It's not in the strict sense of a must, but there is that probability if your first degree relation has a cancer. So that is in general some of the general causes of cancers. Thank you. Over.
Okay, thank you very much. So you actually said a lot of it's more like what you eat. You talked about food, diet. You talked about things around those, air pollution. You talked about obesity. You talked about tobacco. These are basically what people do. And then you also talked about first degree relation, hereditary. So I don't know if you can share more light, particularly on the hereditary, hereditary aspect. How does hereditary lead, for example, to some of these cancers? And if you could also give examples before we go to Dr. Ajay, what is the link between hereditary and cancers generally?
So this will be more of a study of genetics, but then it's just an interplay of your genes. It depends if, for example, your father has a cancer or your mother has a cancer, and then they give birth to you, and then during genetics, it's the faulty gene that you carry that is transferred to you, and it happens that that gene is dominant. There's that probability that you might end up with a cancer. But then it's not, like I said, it's not in the strict sense of because your dad had a cancer, you would end up with the cancer. No, it's just an eye opener for you to be more watchful, to engage in regular screening. For each kind of cancer, there are certain durations, a period of time which after you have to go for screening. For breast cancer, prostate cancer, they have different durations where you have to go for screening. You have to watch your diet, what you eat, and all those other risk factors like obesity and everything, because those are the things that are now going to put you at risk, at a higher risk already. I can say at a greater risk because you are already at risk of developing the cancer because your first degree relative has it. But then if you don't watch over these other risk factors, these other dietary and lifestyle behaviors, you might now be at a greater risk of developing the cancer. Then what still, if you are not engaging in regular screening, you might end up with the cancer, and even at the later stage of the cancer because you were not checking on yourself regularly. So it's a more complex, a complex reaction that occurs during genetics, which I might not be able to explain here. Everybody will not be able to understand. But you should just know that if you have a first degree relative that has a cancer, there is that possibility that there might be a transfer, but it is not certain. So there's just the genetic, that's why I call it a genetic susceptibility.
Okay, so if I get you right, basically from your explanation, it is basically an interplay between genetic or hereditary, environmental, and lifestyle behavior. So an interplay of these things basically is what could predispose a person to having cancer. All right, thank you very much, Dr. Esther. I would go straight to the radiologist in the house. Now, because we have both male and female, and what I'm going to do now is I'm going to divide one to Dr. Ajay and then one to Dr. Demola, they are the radiologist. So let me start with Dr. Ajay. Let's talk about female cancers. Okay, cancer in female. can we talk about the commonest cancer in female and how can we, what are the risk factors basically in those female? What are those things that can cause that? I want to just pick only one, you know, and talk about it extensively. What are those, the ones you see commonly or common in our country, Nigeria, and what are those things that leads to them, the risk factors? So let me start with Dr. Ajed. So you talk about female cancers.
Okay. Cancers that affect the female folk, we'll look at breast cancer and we'll look at cervical cancer. But I think I will zero in on cervical cancer because I think the discussion on cervical cancer is topical now, and probably my other colleague would take the discussion on breast cancer. So cervical cancer is, of course, it's cancer that affects the genital part of the woman. It's broadly described as one of the gynecological cancers, and is the second leading cancer in our environment. And it comes after breast. So, and interestingly, cervical cancer is one, preventable, and is treatable if you present at a very early stage. And the reason why it's preventable is because of the fact that over 90% of cervical cancer cases have been associated with a causative agent, which is the human papilloma virus. It's a viral agent that is spread through human behavior. And that is why a whole lot of emphasis is placed on prevention, vis-a-vis counseling, change of lifestyle, you know, and modification of lifestyle, and also vaccines. These important stems in prevention strategy are germane in the control of cervical cancer. The way it presents with abdominal vaginal bleeding, which is usually outside of the lady's menstrual cycle, which it could present as either drop bleeding, which is commonly referred when a woman says that she's bleeding and the bleeding is coming in small drops. When it's not controlled, the disease is not nipped in the bud at that level, then it becomes frank bleeding. And it could be so bad that the woman could complain about dizziness or that she has to be using a pad at all times. It affects women of all ages. Usually before now, some 5 years ago, 8 years, 10 years ago, it was affecting women in their post-menopausal age groups. But we're beginning to see women in the third decade, the fourth decade of their lives coming down with cervical cancer. In discussing the risk factors, there are factors, as I said, that has to do with human behavior, and that is factors that have to do with uncontrolled or unbridled sexual activity. You have someone who has multiple sexual partners, the partners have multiple sexual partners. There is people who engage in some degree of same sex, same gender sexual activities. Then you could have those who fall under other risk factors that are extra HPV risk factors, smoking, alcohol consumption, then the social life, the social cultural milieu that surrounds the individual. So these are some of the risk factors that will subject a person to coming down with cervical cancer. It's also important that we mention at this juncture that it's a lot of people have these viral agents in their genital areas, right? But it takes a process of infection and reinfection and a duration of about 15 years before you begin to come down with the signs and the symptoms of cervical cancer. If I might just reiterate again, principal signs and symptoms that you should watch out is when you have abdominal vaginal bleeding, or you have post-coital bleeding, or you have a watery vaginal discharge, which may be offensive or non-offensive. So these are the things that our viewers and our listeners need to watch out for as I mean, as a way of having to monitoring themselves, particularly if they are at risk. We looked at the risk stratification. Those who have you have multiple sexual partners, your partners have multiple sexual partners. The early stage of coital debut is also very, very important as a risk factor to cervical cancer treatment. I think I may just stop for now. Thank you.
Wow, that's so much. Thank you very much. If I can just emphasize some of the things you talked about. You talked about that cervical cancer, of course, is one of the preventable cancers because, of course, there's something you can prevent with the vaccine. You also made mention of human papilloma virus being one of the one of the things that have been implicated when it comes to those. You talked about early sexual debut. That is when people are exposed to sex very early. You talked about multiple sexual partners, people who sleep around with multiple men. And then you talked about also that, of course, you talked about the extra one, like the tobacco, smoking, and the rest of them. And you went ahead to tell us about some of the symptoms, where you talked about abnormal vaginal bleeding, and then and after sex, postcoital, which is bleeding after sex, so people like that, of course, and talk about discharges which could also be foul smelling. Thank you very much. And you said, yeah, those are much for cervical cancer. All right. Before we go to the prevention, I think I also want to hear about breast cancer because we are talking about February here now. So, Dr. Oyeko, I don't know if you can run us through breast cancer. Recently, I saw a young girl who was just about in his 20s, and then in a clinic, and when we examined the breast, we saw that there were a lot of things that look like lump and stones around the breast. So please, sir, can you really take us through breast cancer? Over to you.
All right, thank you very much. So we can see that the incidence of breast cancer is increasing, and the risk factors, I would want to talk about them, classifying them into modifiable and non-modifiable. So the modifiable means that, yes, you can do something about it. And I think we should start with that. So first thing is the number of children. Reduced parity, that's a reduced number of children for people that have none or just one, that increased risk than those who have more children. People that do not practice exclusive breastfeeding for their children, they are also at increased risk compared to those who practice exclusive breastfeeding. Then the age at first pregnancy, we have realized that people that get pregnant at a later age, reproductive age, they are at increased risk compared to those who get pregnant earlier. That means they get married and they get pregnant earlier. Use of hormone replacement therapy, well, is no longer in use, but we still have to talk about it. There was a time that, when people get to menopause, they still use some hormones to just look younger than their age. It is currently discouraged and is no longer in practice, but it's something that is worthy of being mentioned. Previous exposure to irradiation is also a risk factor that increases the risk. A lifestyle like obesity, physical inactivities, and I think we are beginning to adopt the Western lifestyle, and it's affecting us. Sitting behind the computer, working from home also promotes all these things, because by the time you are not active, you are just behind your computer from morning till night, do that 5 days a week. It puts you at risk of not just cancer, but other chronic diseases like diabetes, hypertension. So, and also obesity. Smoking, alcohol increases the risk. the diets that we consume, like the low fiber diet, high fat, also increases the risk. And I must say that the socio-economic factors, as the monetary aspect also is a risk factor, because it puts people at risk of taking junks and they don't eat proper food. So those are for the modifiable things that we can change, the things habits or behaviors or things that we can do something about to reduce the chances. So for the non-modifiable, I would want to start with the age. I mean, the higher the age, the higher the risk of coming down with a cancer. But for us in this part of the world, we realize that the age compared to our white counterparts, the age is lower. So we see cancers, breast cancer occurring in people less than 40, less than 30, less than 20. We've seen that. Then being a female, I mean, makes you at a higher risk of breast cancer compared to your male counterpart. Yes, there's also male breast cancer, but you're causing just 1% of the whole population of people that come down with breast cancer. Then the race, it increases the risk. We found out that the white people actually have a higher risk of developing breast cancer, but I mean, for us Africans, we have a higher risk of having a more aggressive disease. So I'll also talk about genetics, and I think Dr. Esther has elaborated on that. We have a number of mutations that could occur for one reason or the other that could be passed down to the offspring. Then the family history of a cancer also puts one at risk. And I think we should be able to separate that, because sometimes you may not be able to pinpoint and say, oh, this is the gene that is involved. But the fact that there's a family history actually puts one at risk of developing a cancer. So early menarche, late menopause, people starting menses earlier than usual, I mean, puts them at risk. And I've realized that, I mean, in this age, in this time, or the age where we are, we realize that girls actually start menstruating early. We've seen girls like 10, 11, they start menstruating, unlike before where you see girls before they start menstruating, they will be like 16, 17, 18. And late menopause, we usually take them together because it has to do with the estrogen window. So how long does the person get exposed to estrogen, always menstruating? So those are things that we look at. So the later is somebody that is attaining menopause at 55, 56, 57. Person has a higher risk of developing breast cancer than the people that stop menstruating at 48, 49, and that. So then there are other conditions, benign breast conditions that could occur, like atypical ductal hyperplasia. But I don't want to go so much scientific. I want to be as basic as possible. Wow. So I wouldn't dwell so much on that. Then previous history of breast cancer or other gynecologic cancer also puts one at risk. And I think with this, we shouldn't bore our viewers with so much scientific information. But I think these are the basic things that are needed to get going.
Wow, that is much of download of information. Wow, modifiable and non-modifiable, and it seems like the cancers all just have almost similar. Of course, we are hearing obesity again. We are hearing smoking. We are hearing alcohol. We are hearing diet. Of course, socioeconomic status. And then just you talked about age at first pregnancy, and then you also talked about non-modifiable, that things we really cannot change. And age, and as we age, as women age, they are more prone to having cancer. And like you said, of course, younger girls are coming down with this now. I mean, maybe the science we have to explain to us why that is happening. talked about female. You talked about race. I didn't get that. Which is cancer, blacks or white? I didn't get that part, if I may ask. Dr. Iko.
Okay, so for breast cancer, generally, it's more in Caucasians, but we tend to have an aggressive type amongst blacks. And the blacks tend to present at a late stage because of the aggressiveness of the disease.
Okay, so like Dr. Ade, so how really can somebody know that this person, what are the, if I may say, signs and symptoms that somebody may have breast cancer? What are the early symptoms and what could be the late symptoms? If you could take us through that.
Okay, so basically, we look out for lump. That's the most common symptom. It's important that as a woman, you are taking your bath with the soapy finger, you can use that to go around clockwise or anti-clockwise around your breast and palpate and see if you feel anything. You don't have to do that every morning when you are taking your bath, but you can do that once in a week, once in 2 weeks, so that you won't get anxious because of the fear. And then, so apart from the lump in the breast, the other things that we see is changes in skin color, itching around the nipple areola area. Then you can also observe some people to be having bleeding or abnormal discharge from the nipple. So which could be blood or for somebody that has passed menopause and you are noticing a milky discharge from the breast, somewhat abnormal. So you don't expect to evaluate that. And then for some people, quite unusual, they may not even notice anything in the breast. So it may just be in the armpits. Yeah, doctor, I noticed a lump and I used antibiotics and it went down and it came back again, and it went down and it came back again. So some of them is a lump in the armpit, and it's not so common as a presentation, but it could happen. But the common ones are the lump in the breast, the skin changes, and the abnormal discharge from the nipple. Thank you.
Oh, thank you very much, Dr. Oyiko. Dr. Balomp, I believe these are some of the earliest signs that you see when somebody have a lump like, of course, like seed, very tiny stuff that you may see. You talk about itchy, talk about discharge from the breast. Also, when there's changes, of course, in the skin around the breast. And you said something very important that I really also I've seen happen. I mean, I've lost friends, and all they noticed basically was that they felt some things in their armpits, you know, some very, very funny sensation of very funny kind of lump, you know, under their armpit, and that was how they were able to know that they, of course, they had breast cancer. So thank you very much, Dr. Demola, for that. Before I move on, please permit me to quickly acknowledge some people I have in our midst. Everybody's important, definitely, but I have the Secretary of the Nigerian Medical Association, Lagos State Zone, and the person of Dr. Ismail Ajibowo. Thank you very much for knowing our invitation. We also have another important person. Like I said, everybody's important. The neurosurgeon, person of Dr. Edward Jolayemi, another very senior person. We have people from way back from Ibadan, from Dr. Akonji Williams Akinola from Heritage Comprehensive Ibadan. Thank you very much. And also we have some people on Facebook because we are live streaming on Facebook. So thank you very much for joining. So what we have been doing is to bring about the to create awareness on what breast cancer and the of course the cervical cancer, which are the two most commonest cancers that we see in women in Nigeria. I don't know if Dr. J can quickly, in a few minutes also, let's touch one about men, because I mean, most times it's all about female. Can we quickly talk about prostate cancer just in a few minutes before we talk about prevention and other aspects of this discussion? Dr. J, over to you, sir.
All right, thank you very much. Prostate cancer is one interesting cancer that apparently affects the male folk. It occurs in the 5th to 6th decade of life, sometimes in the 7th decade of life. And you know that the prostate is the one organ that differentiates a man from a woman. So it's an exclusively male cancer. However, there are some cases, incidences where we find prostate cancer in men in their 5th decade and sometimes even younger, and those diseases are usually very aggressive, excuse me, and their progression is rather rapid to a metastatic to the metastatic endpoint for that patient. It's important for us to know that prostate cancer is more associated with, it has a more ancestral and a genetic leaning towards the African man, or what we call the African American. It's more common in the African American man, or in the African man, basically. And it is the African gene that has a rather aggressive kind of the disease. So what you're looking for in man as risk factors is family history is very important. That ranks at number 1 after the person's race being an African. So the family history is important. Person has an uncle or a father that has that was treated for prostate, then you should monitor. You should monitor your prostate health. After the family history and the ancestry, the race and the ancestry, diet now comes into play, where you have a lot of those who take a lot of processed food, processed meat, low fiber content meat, or low fiber content foods has been implicated. However, where you have people who've taken up a habit of consumption of tomatoes because of the lycopene ingredients in tomatoes have been found to be protective, and a lot of fruits and vegetables have been found to be protective to prevent against prostate cancer. So by way of symptomatology, prostate cancers will begin with symptoms or features of lower urinary tract symptoms, where you have symptoms of frequency, of urgency, nocturia, or you have a complete urinary obstruction when it does happen. There's this gray area between benign prostatic hyperplasia and prostasia. But the way with which we separate that sometimes, or most times, aside from the clinical evaluation, is you run a PSA. When you run a PSA, there is an elevation of the prostate specific antigen, which is a protein in the blood that is highly elevated in those who have prostate cancer, as against those who have benign prostatic hyperplasia, even though they may present similar, but the PSA estimation separates both clinical entities, from each other. Maybe I should just mention this, that at the very late stage of the disease also, we have features of sudden fall or low back pain or sudden inability to use both legs. These are signs of advanced disease that you find in prostate cancer that you may not find in benign prostatic hyperplasia. Well, treatment is available, and but let's dwell on how we get to know, or you have an uncle who who is above 50, the message to such folks is that they do a medical check, at least a simple PSA check, be able to keep the mind calm, and you know that your prostate is in good form. I must also mention the role of exercise. Exercise is very, very good in preventing most of this malignancies, as we have in breast, as we have in other malignancies. Exercise also play a key role in prostate health. Thank you.
All right, thank you very much, Dr. Ade. This is looking like so much information as is more common in Black as you grow, and there is a possibility of the prostate to get bigger. And then you also talked about the commonest symptom being, of course, urinary symptom, difficulty to urinate, and then, of course, sometimes when people urinate, they see blood. And then you talked about PSA. So thank you very much. We'll just go straight to the next thing, and which is basically why is it that people who have cancer usually die? Because whereas, of course, in other climes, they have cancer and they will tell you they are cancer survivors. So what exactly is the issue with our own climate? We're talking about Africa and Nigeria right now. So maybe I should start with Dr. Esther, and then I will go to the clinical oncologist. Dr. Esther, why do you think that you talked about over 700 deaths annually from cancer? So what could be the reasons why from cancer? Dr. Esther, over to you.
Okay, thank you very much for this very important question. In Africa, we should know that we have not yet come to the realization that cancer is actually a public health emergency. It's a very serious problem. And so serious problems need serious investment. So our governments need to be able to invest a lot of money from the screening, from the prevention, screening, management, and even at the level of palliative care. We need investment. Cancer patients in Africa, they struggle. They struggle to buy their drugs. They struggle to go for treatment, radiotherapy. And that's why even their diet, even the kind of food they eat, they don't have access to quality food. They don't have access to healthy food, because once you have cancer, it is very imperative for you to eat healthy. If not, you'll just be feeding the cancer cells with the glucose that they want to continue thriving. So it's important that in Africa, we should prioritize cancer and treat it as a very serious problem, and invest in cancer, subsidized cancer care to ensure that everybody who is diagnosed is placed on proper treatment and is being followed up at the tertiary center where they have the facility. That is the second point. Do we have the facilities for treatment? We have our radiologists here. They will tell us if they have enough equipment, to carry out treatment and follow up. All of those things, they are very important. How many scans do we have? People say we want to do screening for the entire population, even on a monthly basis. We will be able to cope with the population that we have, the equipment, the drugs. Are they affordable? Are people able to get the drugs to buy them? So those are some of the things that cause the increased amount of death that we see in Africa. We don't yet have that subsidized. I'm not even sure if our insurance plans cover cancer treatment. I'm not quite sure to what extent, and if it's in every country or not. So even though we are called developing country, we have to set priorities. And it is very important that every country has a national cancer control plan. It's very important. A strategy that they use and that they are working towards, they are implementing to ensure that all cancer patients, they have access to care, they have access to treatment, which is affordable and which is comprehensive. As long as we don't close that care gap, we will keep having this increased number of deaths, which we see every year, and having high prevalences, annual prevalence incidence of 1 million annually. Thank you.
Wow. Thank you very much, Dr. Esther. You've talked extensively, even to things we were supposed to discuss afterward. But things could get from what you talked about. One of the reasons why we have higher deaths or higher mortalities is simply because there is no adequate investment, of course, in that field. We don't have enough facilities, to treat them. Also, the costs of course, of assessing those care, even when we diagnose, which is another thing. We need equipment to diagnose, and those equipment are not there. And then even the people themselves are poor. And then you now talked about the last one, which has to do with even the cost of the drug itself. That's so interesting. And interestingly, that is part of the thing we are discussing this year. The theme for this, for World Cancer Day, is about closing the gap, the inequality that exists basically in the cancer care. A lot of people die because of this inequality. Number one, there is no available facilities. There's no available, even the specialists are not enough. And then the location when you have this facility is really, really far from the people. And when they get there, they don't even have the resources, the cost, the socioeconomic status are part of those things that is leading to. Thank you so much, Dr. Esther. Please let me, before I go to the next one, I want to appreciate some of our people on Zoom. I can see Dr. Nastiza Isika from Calabar. Thank you for joining. Dr. Owolabi Eunice from Oshogbo. Okay, we have somebody from Canada, Dr. Anna Okerinde. Thank you very much, from all the way from the White Man Land. Thank you very much for joining Dr. Jumbo Enifio from University of Uyo. That's the president of the AL. They really appreciate you. We can see some other people online and also on Facebook. Please let us know where you are joining from so that we can appreciate you. It's like I said, this is basically brought to you by Sun Alliance Foundation. It's just an organization that a non-government organization that creates awareness on issues around health, education, leadership, and advocacy. All right, I think another important aspect of this discussion, which I want us to spend more time on. I'm a public health physician, and I always believe that prevention, they say, is better, is cheaper, and than cure. So I'm going to go to the radiologist now. I know that you may not like this, because if people don't have cancer, you cannot treat them. Okay, while we in public health, we don't want them to come now with the disease. So how can we prevent cancers generally? How can we prevent? So let me start from Dr. Demola, and then I go to Dr. Ajay. How can we, all these cancers we are seeing, the increased incidence, how can we reduce them? Over to you, Dr. Demola. I think you are muted.
Right, thank you. So basically, I would say that the burden is much for us. We are overwhelmed. So if you think that we are not tired, I think probably you are getting it wrong. So the prevention of cancer can be addressed at the level of primary, secondary, and tertiary. Those are the basic modalities that we need to we can use to address them. So for primary modality, I mean the place of health education, health awareness, just like we are doing, we are making people aware, I mean, encouraging them to be aware of their body and go for screening. The second thing is vaccination. For those cancers that are vaccine preventable, I think
Hello, Dr. Demola, can you hear us? Hello? Okay.
Sorry, I just had some small interruption from
Okay.
my chiefs at home. So we can do vaccination for those cancers that are vaccine preventable. The place of cervical cancer, and I thank the federal government for what they have in the pipeline concerning cervical cancer vaccine, planning to vaccinate about 17 million girls starting from the third quarter of this year. I think that's a good feat. There's also vaccine in the area of hepatitis. I mean, we know that the majority of people that come down with hepatocellular carcinoma actually have an underlying hepatitis, either acute or chronic. So, I mean, taking vaccine, especially the hepatitis B vaccine, which is very much available. It may not be affordable for everybody, but there are policies that could be made by the government to ensure that those things are accessible to people and they are able to get it. So that's at the level of primary. So I've talked about the health education, awareness, and the vaccination. Then at the level of the secondary, we are trying to ensure that people are screened. So we encourage people to go for screening. So there are a number of cancers that could be screened. I mean, I know that as a public health physician, you know a lot about the area of screening. And for you to screen a cancer, you must be able to cure the cancer. And the cure should be affordable. So you shouldn't screen a person for an incurable cancer now and you just put the person in limbo. You want to go further and be able to cure the person. So for some cancers that have established screening modalities, like breast cancer, which from age 40, the woman can go for a mammogram. And for some people, they can have an MRI of the breast or breast ultrasound scan. I mean, I think we're already drifting away from clinical examination, clinical breast examination, because we have found out that it doesn't really make so much difference. Yes, it can still be done at that level where those things are not necessarily available. I mean, those machines. So, but clinical breast examination, self-breast examination, we can still do them, but established ones are the mammogram for breast. For prostate, we have the place of the prostate specific antigen, where a man from 50 and above can have his PSA done, and will help him to monitor it from time to time to ensure that if there's anything coming up there, we can pick it early. You can also have a digital rectal examination, and if anything funny, if anything is found that to be funny, they can go for a further test, maybe a prostate ultrasound scan to look at it. Then for colorectal, I mean, there are endoscopies that could be done. We call it colonoscopy. You can look at lesions that are arising on the lumen of the intestinal tract, and we can check them from time to time. That is done every 10 years for colonoscopy. Then there's rectal sigmoidoscopy, that's done every 5 years. Basically, that's that. Then for cervical cancer, so we can actually do a pap smear for cervical cancer, pap smear and HPV DNA testing. So for women from 21 years above, it's believed that they are sexually active. So we want to do a pap smear for them and rule out early pre-invasive disease. You can also do HPV DNA for them to know if there are presence of HPV, whether they've been infected before or there's an ongoing infection that's become chronic. So basically, we can do that. I mean, I think those are the basic ones amongst the common cancers that we could do screening for. Thank you.
Wow, thank you very much, Dr. Ekong, Dr. Demolo Ekong, for that extensive stuff. I love what you talked about, the various level of prevention, where you talked about the primary, which is one of the one that we personally, primary and secondary, we always advocate for. Of course, there is a place for health education, and that is why we are holding this to educate people on what cancers are, on how you can prevent them. And like I said, early prevention is better than, of course, than cure. You know, so like we talked about earlier, the risk factors, the diet, so that more of primary things. You know, we educate you on what you eat, just all the things that Dr. Esther has talked about, your diet, physical activities. Of course, we emphasize that you live an active life, you know, you exercise, you watch what you eat, stay away from a lot of fatty food, all those burgers and everything that you eat that are very oily and fatty. They really are not good, and they could be risk factor for almost all forms of non-communicable diseases. We talked about all the sugary things you take, which end up, of course, into being stored as fat. So those are at the primary level, and also, like you also said, have legislation or policies that is put in place. And the secondary, like Dr. Demola also said, has to do with early screening, and then of course prompt treatment. Okay, and early screening or screening itself basically is just to be able to pick the disease early, and when you are able to pick it, like he also said, like breast cancer, when you are screened and you pick it early, you can be treated and you'll be free. But when you wait for such lump or such cancer to grow and, you know, and now become metastatic, where it starts going to other part of the body, at that point, there's little or much that they could do. And interestingly, that is how our people present. They usually will present late. You know, they will have rubbed anointing oil, you know, do all those things, go to church to pray. Once you see anything that is abnormal or abnormal growth, please kindly report to your facility. I don't know if Dr. Ajay want to add one or two things on, you know, to what Dr. Demola has spoken about before I go to Dr. Esther on prevention. What are the other things that we could do in order to prevent or to these cancers we're talking about?
Well, I think Dr. Oyeko has dealt on the topic of the subject of prevention extensively. I think we can move on to save time.
Okay, thank you very much. It also talked about cervical cancer. Please, once you are sexually active and you are getting to a particular age, please make sure you go and screen do your pap smear and everything. Yes, closing the gap, the care gap. We all know that cancer treatment is expensive. This is where I'm coming to Dr. Ajay right now. For example, how much really does cancer care cost? Can you give us an idea of, you know, the cancer patient that you see? How much does it cost to treat? And even when you treat, did it get cured? I don't know if that question is clear.
Well, thank you very much. Yes, you cannot look at the cost of cancer care in isolation without looking at the cost of the service in itself. Now, the cheapest way in treating cancer is the prevention. Sorry,
Dr. Ajay, sorry, please. Sorry, before you answer the question, let's talk about, before you talk about the cost, how accessible are these care centers? Are they really readily available where people can access this care? Let's start with that, and then you can zone into the cost. Are the facilities available?
Yes. I mean, we can say now that we have like at least 4 modern day international standard facilities in Nigeria where you can access health. Just last week or upper week, the president was commissioning the cancer care in Kano, right? With the state-of-the-art equipment. And the interesting thing in oncology, I tell people that oncology is the only aspect of medicine, or radiology or radiation oncology is the only aspect of medicine where our equipment mirror what you find abroad. So someone comes and says that, okay, I want to go to the UK, I want to go to the US for an oncology treatment. And I tell them that you'll find the same equipment in Nigeria now as akin to what you find abroad. What you may not find is the white man's skin, or you have a brown skin person here, and you have a bleached skin abroad. That is the only difference that you have. The equipments are the same, the expertise, the trainings are the same. We do MDTs with colleagues in the UK, in the US, in Europe, in Australia, and we have standardized practice. So you ask us what we do here, we'll tell you what we do here based on our factors, and they tell us what we do there based on their factors. The difference between our community and the white man community is that they are very high on prevention. They are high on public enlightenment. Their insurance is, everybody's on insurance. So there's really nobody paying out of pocket. So you cannot discuss care without having to discussing one, service, then discussing the enabling environment with the individual person and with government. Right. So in discussing so I mean, answering your first question, centers are on ground with trained and qualified professionals. We have here in Lagos, at least there are 2 functional centers in Lagos. There's the Maserut Center in VI, and there's a Lut Center in Idiaraba, Surulere. And I'm aware that Lagos State University, this Lagos State itself, is working hard now to put a center in Lasut, right? That makes it 3. And there are other private centers who are working also to bring in their machine. Mikio is working hard to bring in their machine. That makes about 7 centers in Lagos. There is 1 in Calabar. There's 1 in Enugu. There's 1 in Meduguri. Meduguri is going live in April, thereabout. Kano has gone live, right? So if you look at the spread, it may not be in every state, it may not be in every geopolitical zone yet, but you cannot compare what we have now to what we had 5 years ago. So the services are available. Now, we should be talking about whether they are adequate. So that's why it brings to mind what Dr. Yekon said. We are not interested in you coming down and we treating you. We're interested in you preventing the disease, so you reduce the burden of our treatment. Because we have burnouts with our healthcare workers. We have psychological breakdown with our healthcare workers. And we have people who come every day with the morbidity and with the burden of the disease. And as it were, you wish they didn't come down with it. So that's why for us, and for me particularly, I'm very strong on prevention. I'm very strong on lifestyle modification. I'm an advocate of vaccines. I was in a radio show and I was telling them that if all our state governors can take the initiative of vaccinating secondary school girls from GS1 for the next 8 years, we'll eradicate cervical cancer. If they take that point of responsibility to create a change of lifestyle, we'll eradicate cervical cancer. Our numbers will come down drastically. So the centers are available. The manpower may not be adequate, but I think that with the manpower we have now, we are covering grounds. Now the cost.
That's quite encouraging that we are getting more these days. So yes, to the cost. How cheap is the service?
The healthcare is not cheap. There is nowhere in the world where healthcare is cheap. What happens is that there is a partnership between individuals and government that makes healthcare look cheap. Healthcare is not cheap. Even in the US, if you go to the US today and you want to run some investigations, if you're not on insurance, you cannot. You can't take on the cost of running an MRI, running a CT, running a full medical check in the US if you're not on insurance. So that is where the difference comes within their climb and our own climb. And that's why we have the beauty of this kind of program, because I know there are politicians listening to us. There are yet to be senators and House of Rep members and even presidents that are listening to us, so that when you get there, you remember that we should make healthcare affordable to all. The NHIS program should be all embracing, should be all encompassing. So government bears a cost, an individual bears a cost. But if you look at it on paying out of pocket, is expensive as it is in everywhere in the world. In Western climes where patients are registered on clinical trials, there are clinical trials going on. Somebody is funding those clinical trials. Somebody is funding those programs. But there are no clinical trials here because we feel that health in the Black man's land should be free. So there's nowhere in the world. Please bear me 1 minute.
Okay, so okay, it's back. All right.
So there's nowhere in the world where healthcare is free. So it's expensive, right?
So Dr. Ajay,
if you're going to, sorry,
I want to be practical here. For example, okay.
So that I don't lose train on my thoughts. So if you're going to have treatment in Lagos, for example, it's not going to cost you anything less than 1.5 million.
Wow.
Yes.
Can you break it down? The 1.5 million averagely is it all cancer or a particular one? And how did that 1 million, 1.5, for example, come to be?
Okay, maybe 1.5 is from a conservative look, because in cancers where you need to do surgery, for breast cancer, for example, surgery, I mean, where it now depends where you want to do your surgery. If you want to do your surgery in an eyebrow hospital in VI, you might be paying as much as 2 million or 1.5 million for the same surgery. A mastectomy that might cost 500,000 naira, maybe somewhere in Ikorodu, right? So that is surgery in itself. Then the medications are not produced. We don't have a local lab in Africa. We don't have a local lab in Nigeria where those molecules are being produced. These molecules are imported. So that is the burden of the disease, the financial burden of the disease. The molecules are imported into the country and at a cost. The molecules, when they get into our shores, we have to be cleared. We have NAFDAC people coming to look at them. I know all of these things bear a cost. Now, you could imagine how much a variant made or a Siemens made machine is going to cost. But for an individual who's going to come for treatment, that cost of that machine is going to be about 1 million or even 1 million plus. So these are the realities of the burden of the disease. So sometimes when patients default, it's not they don't wish to default, but they don't have the financial wherewithal to meet up with the demand of treatment. So if you're going to add surgery to the 1.5, it probably maybe we'll be getting to 2 million thereabout. Now that depending on the kind of cancers. But I can tell you for free that most head and neck cancers will cost more. Because aside from the surgery, there are some prostheses that may be fixed in some parts of the body in that region to make living more comfortable for the patient.
Wow.
So this is where I think the meat of this discussion is, because as tomorrow's policymakers, as tomorrow's politicians, let's separate ourselves from the rest of the pack who is just thinking about themselves. Let's see how we can alleviate the burden and the harsh hand of cancer on the victims. And I want to borrow from what Mrs. Esther says. It's becoming a pandemic, it's becoming a public health issue, and the attention that should be given to it should be given as such. Thank you.
Wow. Thank you very much. We are at the final lap of the discussion where we'll be talking about what we can do basically to close the gap. I mean, 1.52 million for just a cancer, and then of course more depending on the cancer is a big issue. I'm aware that there's NHIS for some, and really that can cover. So the last part or the last segment will be our recommendation. How do we think we can close the gap the care gap, because everybody needs to be able to access cancer care. But before we do that, I want to really acknowledge a lot of people who also joined in. Dr. Adewale Akinbolasere from Edo-Ekiti Federal Teaching Hospital. Thank you so much for joining. Dr. Eze Akim Tokumbo, wow, all the way from Kaduna. Thank you very much for joining in. We have also in our midst the #1 medical doctor in the Lagos State, like I always love to call him, the person of Dr. Benjamin Olowo Jebutu, the NMA Lagos chairman. Thank you very much, sir, for joining. We're going to give you a few minutes for, more likely you give us a closing remark. We're supposed to take early, but we'll take you. We have some other people. Thank you so very much, really, for joining in. There are some questions. We'll see if we can take them. But yeah, like I earlier said, the final wrap. Let's look at, and I'm going to start from what can we do? What is the way forward? How can we close the care gap for cancer care? And I'm going to be starting now. I want practical solutions. Okay, practical solutions that we can recommend to either government, individuals, and everyone. So, Dr. Esther, how can we close the care gap? Over to you.
Okay, thank you very much. Before I answer that question, I just want to add to what Dr. Ajay said. Apart from the financial burden which we have, we also have the emotional and mental effect or burden, both on the person who has the cancer and on the caregiver, which is something we should not underestimate, and it's very important. So aside the fact that we have that financial burden from cancer, we also have the mental, the emotional, and the physical burden that we have to deal with. And so it's something that we have to tackle holistically. So we can address this, I can say basically in 2 ways. We have at personal level and we have at national level. Personal level is what we ourselves, maybe we as the patients, what we can do for ourselves, because nobody can take better care of you than you. So if you already know that these are things that if you eat will worsen your cancer or would proliferate the cancer cells or will lead to cancer, you avoid them. You make sure that you watch out for them, like what you mentioned, the sugary and the high fats and the high sugar and unhealthy foods, physical inactivity, tobacco consumption, harmful use of alcohol, exposure to ultraviolet radiations, and all of such unprotected sexual intercourse. Those are measures that you yourself as an individual conscious about your health and the fact that you want to maintain your health and live in good health, you should take individually. Now, secondly, the next stage is at national level. Definitely, even if you decide that you are going to eat healthy, but you cannot afford the healthy food, it will be difficult for you to do so. If you say you are going to stay away from alcohol, but you find that alcohol is the cheapest thing you have around you, which is even more cheaper than the natural drink that you can purchase, you will find yourself falling back on alcohol. So definitely we need strong measures, regulatory, legislative, and fiscal policy measures at national level to provide an enabling environment for people to make healthy lifestyle choices that will keep them away from having these diseases. So this is where we need not just governments, because sometimes we put only the blame on government. What about the NGOs? What are the NGOs doing? What about the civil society organization, academia? We need everybody on board. Academia, they are there. They wouldn't say maybe we don't have the finances to give. It's not just all about the finances. What about the research? You can produce groundbreaking studies that can be a breakthrough to the treatment and management of cancer. So we need everybody to come on board to tackle this, most especially at the financial level, like I mentioned before, the investment. We take a look at the work that has been done on HIV. It's not just at the level of the government. We have so many organizations that have invested in HIV. And today you see HIV treatment is free. So we need that investment. We also need those policies that will provide, that will make healthy foods to be cheap. We know we have a problem of poverty in Africa. We are a developing country, yes. So we need to apply context-specific solutions to manage our problems. We don't globalize. We know we have the best practices, yes. But when we get those best practices, we look at our context. What are the main things the people in our context are suffering from? How can we help them profitably? Is it to subsidize the vaccines? Is it to make access to subsidized treatment? Is it to provide equipment? Is it to put into place policies that prohibit the sale of tobacco, the sale of alcohol, or policies that subsidize healthy diets such that healthy diets are affordable, they are available for everybody to access and consume? Because without this enabling environment, it will be difficult for someone who does not have enough funds to make all the decisions. Today, I'm going to eat healthy, I'm going to stay away from alcohol, all of that. I'm going to buy my drugs and stick to my treatment when he doesn't have the money. So we need, everybody has a role to play, from the policies to the research, to building the capacity of stakeholders, to the development of, like I said before, national cancer control strategies and plans. How can you tackle cancer when you don't have a national cancer control strategy? It's difficult. So we need those strategies, we need those policies in place, and the individual themselves, they have to take the initiative to work towards living a healthy life. It's only when we come together and we apply a holistic, person-centered approach that will be able to tackle cancers.
Thank you so much, Dr. Esther. I mean, that was, if you had written an exam with all these things, I'm sure they will give you a distinction, because that was really quite elaborate. So Dr. Ajay and then Dr. Yekon, let's just have our own addition on how can we close the care gap. Dr. Esther has given us a lot of extensive discussion, but let's also come from your own perspective. And then Dr. Yekon.
All right, thank you.
Dr.
Okay,
Ajay,
Dr. Ajay, I think you should go first.
Oh, okay. Well, I think Dr. Esther has, in broad, encapsulated the whole idea of participation, all hands being on deck on the cancer care program, because it's beyond government, it's beyond the patient. It involves social groups. What you are doing is part of the idea of closing the gap. So we all need to have our hands on board to make sure that this scourge is the rate at which it's advancing, it's slowed down, and the effects as minimal as possible. Thank you.
All right, thank you very much. That's so concise. All hands must be on deck. Dr. Yekon, your final.
All right, thank you. I think it's sad that social determinants are actually things that are actually contributing to majority of the gap that we have. Who you are, where you live, who you know, where you come from, what you do, who you love. Those are determinants that actually are contributing to this gap. And I believe that we are playing our home part in enlightening people, which is one of the strategies that we can use to reduce this gap. We enlighten people about cancer prevention. And I think the government also needs to do a lot more in equipping the healthcare professionals in the skills and the knowledge to deliver this treatment at international best practices. And I think it's important that we strengthen our primary health. I've had a number of patients that, yes, they presented early, but at the primary care level, they were not properly navigated. So they got lost, and by the time we are seeing them, the disease is already advanced. And I think that's an area where each and every one of us can, come in at our level to ensure that at the level of primary health care that's delivered in communities, we can strengthen it. We can pressurize the government to invest a lot more in that. Dr. Esther has talked about policies, and I think it's important that we emphasize that the government also needs to increase the resources, and I think we need to also implement. So she mentioned that we don't have strategies. Actually, Nigeria has a national cancer control plan that was drafted in 2018. It's unfortunate that it's not been implemented, maybe slowly, but I think we need to put pressure so that some of those things can be implemented. I think collectively, with all this that has been said, we can, in our own way, reduce the care gap. Thank you.
All right, thank you very much. I think we've spoken excellently from of course, personal taking, of course, taking responsibility for our life, or the way we live, the way we do, the way we eat, and of course, like the pastor said, exercising. These are not dependent on any government. They are responsibilities to be sure that we eat right. Of course, he now talked about the national part. If you're going to get food, the agricultural aspect have to be intact too. You need to plant, you need to have food security so that people can eat healthy. Of course, they also need to tax, which we've talked about. So we need to tax this alcohol that we've been doing. We need to tax the tobacco, which is almost a risk factor for everything. And like Dr. Ajay said, all hands must be on deck. There is a need for the government to be able to fund and create these centers. We also need policies to guide all these things. So these are very, very important. And like Dr. Esther said, it has to be holistic. NGO, individual, government, all the stakeholders must come together to close this care gap. We are wrapping up, but I also want to acknowledge some important people online. I can also see the president of the Association of Resident Doctor, Dr. Abiloye Kemi. Thank you very much for joining. I can see Dr. Shegun Akim Musuti and others. We really appreciate you. I can also see my very good friend, Dr. Grace Bernard, all the way from Enugu. Thank you all for joining. Now, before I allow Dr. Benjamin Lujebutu to have his say on what professional organizations really are doing to also forestall or close this gap. I want our speakers in just 1 minute for their closing remarks. I will start with ladies first. Dr. Esther, you have the floor. 1 minute for your closing remarks. Dr. Esther, are you there? You are muted.
Hello? Yes, Samo?
Yeah, we can hear you now.
Yes, please come again with the question.
So we just for your closing remark, 1 minute for your closing remarks for the section.
Okay. I want to thank everybody for making it here. If you are here today, it means you're taking your health seriously and you're very conscious about your health. Like we have said, cancer is not a death sentence. The most important thing is to know what are the causes of cancer and try as much as possible in your power to avoid them, and find out about your family history, find out about cancer history in your family so that you will know what screening to do and how to check yourself regularly. And once you notice that you have cancer, it's not the end of the world. Try to seek medical attention as early as possible. And I'll also call on our governments. I'll call on our civil society organizations, our NGOs, academia, and also the private sector. Please, let's all come together, join our hands and our heads together, and put in everything we can to curb this problem. Cancers are actually a very, very growing problem in Africa. I think the second global cause of death in the world. So it's something that's really serious. We have to acknowledge it, and we have to put in the resources. We have to put in the technical skills, the training, the facilities, the drugs, and everything that we need. Because if we leave one side behind, we are not still going to be able to overcome it. So we have to tackle from all ends, from all corners, to ensure that we actually, we are able to address this problem holistically, and we are able to curb it. So let's all do what we can. It's not a problem for one person. It's not a problem for one group of people. Everybody is concerned, and everybody should put his hand on deck to address this problem. Thank you.
Wow. Thank you very much, Dr. Esther. I want to say something that Dr. Oritoke also posted. Dr. Oritoke said that there is a need, we should encourage use of local therapeutic solution to cancer care, such as use of herbal compulsion, and which will be cheaper for Africans. I think that is really looking inward. So yes, I think that is also very, very important. We don't necessarily have to import everything. There could be some herbs which we will find out through research that could also cure some of this cancer, but it has to be an investment. All right, Dr. Oyekon, and then Dr. Ajay will round off. Dr. Oyekon, your final statements.
All right, a lot has been said. I think I should just emphasize that everyone has a role to play. I'll take my role, enlighten people as a physician, a specialist, treat as much as I can. I believe that the government also have a role, making policies, investing in healthcare. The budgetary allocation can be increased significantly. And I think the NGOs also have a big role. They can come in the area of investment, they can come in the area of patients navigation, patient support group for those that are newly diagnosed because of the mental health issues involved. I think we all have our role. We should just take it seriously, and I believe in the nearest future, we reduce the burden and bring it down as much as possible. Thank you.
All right, thank you very much, Dr. Dimola, for that. And then Dr. Ajay. Dr. Ajay, your final remarks.
Yes, cancer is not a death sentence. I remember some 20, 25 years ago, hypertension was called a silent killer. And everybody was agog with the fact that somebody could be walking, no symptoms, and he will slump because of blood pressure. Now we have moved on beyond that now, so that it's been labeled a chronic medical illness. Now, cancer is a chronic medical illness, just like any other chronic medical illness. And if we as health providers and health professionals, we look at it from that perspective, then the stigma associated with the diagnosis, the morbidity associated with the diagnosis, cancer is a life-changing diagnosis. If you're breaking the news of a diagnosis of cancer to a patient, it's like the world had just shut down. And sometimes the way with which we doctors even break the news even makes it worse for the patient. I saw someone today somebody was telling me about someone today that the doctor gave her 6 months to live. The doctor who she met 3 years ago gave her 6 months to live. So the woman just packed her things and went to her village to go and stay. Now, 6 months ago, to live. The woman has lived 3 years. She's coming now to the hospital after 3 years, to which a doctor has told her she had only 6 months to live, now with metastasis all over. Now, if at the time when that doctor saw her, which was almost 3 years ago, and she told her to go to a hospital, go to a teaching hospital, get help, you know, she could have gone to a teaching hospital, and gotten people who could help her, and she wouldn't have had the degree of morbidity with her cancer as she does now. Now, she has been able to beat the 6 months. She's beaten the 6 months to 3 months, to 3 years, but now the disease is so extensive to the organs, to the bones, and everywhere that we need all what we can do for her now is just to palliate her symptoms for her. So it's not a death sentence. That's my first point. Then we as professionals should begin to look at it with a possibility eye that this thing is treatable if you have the right information, if you have the right people managing the illness. Then number 3, the lady who raised the issue of the local herb research and things. I want us to be careful, a little careful about that concept, because it's not always true. I rather that we, as we grow in our professional ladder, begin to make a case for research, evidence-based research, where we could have programs that are targeted towards the kind of results that we want. I mean, because we've seen, and I know that other radio oncologists here will agree with me, people who have done local herbs and have had some degree of injury to the kidneys, and they're now coming to the hospital, and we need to measure your renal function before we place you on some kind of medication. And when you find out, they say they've been on these herbs, they've been on that herb, right? I am not shooting it down. I'm somebody who's keen on innovation, you know, and cheaper ways of getting things done. But I rather that we make our diet as rich in herbs, in greens, and in fruit vegetables as possible. Thank you very much.
Wow. Thank you very much, Dr. Ajay, for that wonderful concluding speech. I would want to, at this point, recognize once again the presence of the chairman of Nigerian Medical Association, Lagos State, Dr. Benjamin Olowo Jebitu. Once again, I want to thank him for making our time, and then we would give him time for his speech, his remarks on the subject matter, and also the role that professional bodies like NMA can do or can play to close the care gap of cancer. Mr. Chairman, sir, I don't know if you are still on the call. You have the floor, sir.
Okay, good afternoon or good evening, ladies and gentlemen.
Sir, we would like to see your video, if you don't mind, sir.
No, you can't see me right now.
Okay,
Please.
because, okay, it's okay, sir.
Okay, let me try. Okay. Are you able to see?
Yes, we can see you now. Thank you very much, sir.
It's kind of dark, but I want to thank you for this opportunity to speak. All protocols duly observed. I listened to the very interesting delivery of thought processes by the guests that gave the lectures. They were very, very on point. They knew what exactly they were saying, and they understood clearly that we have a role to play as physicians. One of the things I realized that we need to do as a nation is to speak truth to power and give very practical way forward. What the doctors have done today is to give a population of cancer, vaccinating them, adequately vaccinating, creating an opportunity for them to seek help. They won't seek help on time. So 2 ways we are looking at it is advocacy for prevention and also advocacy for funding of treatment. Very, very important. Dr. Ade spoke about if state government are able to institutionalize policies and advocacy to vaccinate, to give vaccination to all GSS1 students for over 8 years in each of the states. That's a practical way of advocating. So I'll take that as an important point we need to do and write to governments around us and say, if you want to stop cervical cancer in Nigeria or in Lagos State, can you just give vaccinations to all GSS1 students for the next 8 years? These are the things you're going to, this is the amount of money you are going to keep, because it is less expensive to prevent than to cure. So we have to do tabulate vaccination and how much it will cost. And he said minimum of cost of one patient's treatment is 1.5 million, but 1.5 million will have given vaccination to more than over 200 or 300 girls, as the case may be. So for me, we should do as a nation, improve advocacy for funding. Let the big pharmaceuticals that are producing these drugs for cancer set up care center that can give rebate to immediate, which the indigent patients will need this help more. And then there should be specific HMOs that will just be made only for cancer patients. Now that the cancer patients are in Nigeria, let's have funding for them, pull of funds from the high-class pharmaceuticals to government, to big individuals, bring the funds together to especially get these indigent patients help. As I said, Dr. Demola said that we should strengthen our primary health care center. We should strengthen them. Early diagnosis, early detection, early referral. And I would like the referral to be a two-way referral system. So that if you refer a patient from your primary health care center to a tertiary hospital, you should demand there is a follow-up, because sometimes most patients are lost on the way. Why? They will say because of waiting time in the hospital, or they'll say because they are tired, or they're not seeing immediate change in their healthcare status, so they leave. So there should be a two-way referral system, so that when the doctor refers the patients to the tertiary institution or to the cancer center refers the patient back to the doctor in the primary center. So there's a proper tracing, because we have lost a lot of patients in our facilities because there are no proper contact tracing and there's no proper follow-up in that two-way referral system. But I want to appreciate you, Dr. Samuel Okorinde, for bringing this to fore. I think closing the care gap is a responsibility of us, from government to individuals to private specialists, and we must sit down and look at what will make this cost of care reduce and impact of service affect a lot of people more in this country. I don't think we have adequate cancer center enough. I don't think we have enough advocacy. I don't think government is paying the right attention to cancer, because a lot of them have medical tourism and they can leave the country anytime they want to leave. So it's important we speak the truth to power. Let's compare the amount of cancer patients, the amount of cancer centers we have in Nigeria to the amount of cost of cancer care. Let's now begin to what we'll call pyramid of need. So how are the indigent patients getting health care? And also from the private individuals, and also from the pharmaceuticals. The pharmaceuticals, they do a lot of research, and the cost of the drugs are enormous. In our developing countries, there should be a kind of tax relief for them, so that the cost of these drugs can be reduced and effectively help more patients getting help in Nigeria. So for me, a take-home for me is very simple. Let us put all these policy documents together. After this, let's have a little communique and we can add what we're doing. Especially, I love the idea about telling government that if you give vaccination to all the GSS1 students in the next 8 years, we can eradicate cervical cancer. Thank you again for having me today. And I'm grateful to be able to give this closing remark. And I thank you. And I believe that this is one step forward in closing the gap of cancer care in Nigeria. Thank you very much, and God bless you.
Wow. Wow. Thank you very much, Mr. Chairman, for that elaborate contribution. There is a need for us to advocate for prevention, and we also need to advocate for funding. All right, in closing, these are the summary of ways from this panel discussion of how we think we can close a gap. We've talked about that it is very important that we have information, and then there's also a need for us to create awareness. We've also stressed the importance of research and innovation. We've also talked about the place of investing in the system, investing in the facilities, investing in the people. And also we talked about the place of collaboration, that all hands needs to be on deck. And in all of these things, we emphasize the place of advocacy, that there's a need for us to speak to power, there's a need for us to speak to people. We need to tell them about, advocate for prevention, and also advocate for funding. And we ended, of course, by emphasizing the important fact that there is a need for us to strengthen the primary healthcare system, important for, of course, health education, early diagnosis, and of course, prompt early treatment and prompt referral. And, you know, one of those things that we also talked about, that in a place where there is, particularly for cancers that are preventable, of course, with vaccines like hepatitis B and the rest, and even hepatitis, HPV, cervical cancer, we can have screening, and that policies that can ensure that the younger people are vaccinated early can be put in place. I think with this, it's indeed been a very educating, very informative section. And I want to thank all of our panelists, from Dr. Esther, all the way from, she's all the way from Congo Republic right now. She's the WHO NCD risk officer, non-communicable disease risk officer. Thank you very much, Dr. Esther. I want to also appreciate our specialists, Dr. Ademola Oyekon, from specialist with the oncologist, and Dr. Ajay Benjamin, also from the Lagos University Teaching Hospital. Thank you very much for, of course, making yourself available and also informing and educating the people that, of course, was able to join. And I'm sure this video is also being streamlined on Facebook and will be shared on all platforms. I end by also appreciating Ambassador Temitayo Adigun from the GGA group. Thank you so much. I'm just noticing that now. Thank you for joining. I really appreciate you. Now, please don't forget that this was brought to you by Sound Alliance Foundation. This is our own way, of course, of raising awareness on health issue. We also carry out, we are passionate about health, education, leadership, and advocacy. We do this by carrying out free medical outreaches to communities, carrying out health education, and this is one of our brainchild. This is first in the series for this year, and many more, of course, will come as often as possible, where we get to bring specialists to talk on important healthcare matter to educate the populace. I remain my humble self, Dr. Samuel Okerinde, a public health physician, and also the convener and founder of Sound Alliance Foundation. On this note, I want to say thank you, everyone, all the way from Canada and all parts of the country. I want to say thank you for joining us, and please make sure you take responsibility for your health, practice all that you have learned today, go for early screening, take care of your behavior, and then if there is need, also inform others to seek care when there is need to. Once again, on behalf of our speakers and everyone that have joined, and on behalf of Sound Alliance Foundation, I say thank you very much. God bless you all, and let's have a wonderful evening. Thank you to all our speakers. We appreciate you all. I think we've come to the end of this section.
Thank you for having me.
All right, thank you, Dr. Ajay. Thank you, Dr. Yekon. Thank you, NMA Chairman. Thank you to all the presidents all the presidents in the house of the ALDs from Kaduna, from Uyo, from Lagos, from Ido-Ekiti. Thank you all, and let's have a lovely evening. Bye-bye, everyone. Bye. Thank you.